Succinylcholine, what do we use that for? What's the safety concern with that? For example, think malignant hypertension. And what drug do we give to treat malignant hypertension? Think dantrolene. Select all that apply. Neuromuscular blockers, what equipment do you need? Ondansetron, what does that treat? And how do we use it in relation to chemotherapy? When do we give it? The SERMs like raloxifene and tamoxifen, what are the adverse effects? The major ones. Alendronate, ibandronate, which are called the bisphosphonates, what were the big safety concerns with that? When I say big, you're not going to learn like all 10. Do like the, you know what, you should know what the top 3 are. I already told you know everything about steroids. I would know everything about loop diuretics too. Because you notice there's a lot of questions you can throw a loop diuretic in there and it kind of changes the question a little bit. So loop diuretics are the strongest ones, right? When do we give them? What are the couple like kind of safety adverse effects? What other drugs could the loop diuretics affect? Meaning not interact with, but the loop diuretics can cause hypokalemia. So what other drugs would they be bad to give with? It's a little bug flying around here. Iron, what do you need to do when you're given an iron supplement? Either, PO, what do you teach the patient? Iron supplementation, IV, what do you worry about? That's the iron dextran. Spironolactone, what are the bad adverse effects of spironolactone? Respiratory meds, remember BAM SLAM. So use the BAM SLAM to remember the categories. Remember that week it was BAM SLAM and the Made in Georgia. So just use that acronym to remember the drug names. And then a lot of people, I'm going to point out the places where as a group, a lot of people during the term missed a lot of questions. A lot of people missed a lot of questions for the week 1, just the simple stuff like what's an agonist, what's an antagonist, what's the difference between potency and efficacy. A lot of people missed that. But then this week 5, whatever, the respiratory drug week, that's week 5, right? Yeah. So the whole like, what drugs do we give the patients having an acute asthma attack versus what drugs does the patient take every day to prevent getting acute asthma attacks because they have a history of chronic asthma? And then what drugs, once they're in status asthmaticus, should they receive, right? So for an acute asthma attack, they get albuterol or levoalbuterol. But after we've given that once, maybe twice, and the patient is still like can't breathe, then they're an asthmaticus. Status asthmaticus means we've already tried to treat it, right? So what drugs will we move on to, because we've already, status asthmaticus means we've already given the albuterol and the levoalbuterol. What are we trying next?
IV epi.
Yeah, so IV epi, we may try an add an IV steroid as well, or any of those other adrenergic agonists. Why do kids, why do we use the spacer with them? Theophylline, what was theophylline? The therapeutic range. What should you teach the patient not to eat or drink when they're on theophylline? And what's the teaching with smoking as regards to theophylline? Tiotropium, so that's the A of the BAM. Tiotropium, ipratropium. Remember, there's a couple allergies that you shouldn't administer those with. If the patient has an allergy to X and X, don't administer those. Again, I already talked about digoxin, but I'm just going to remind you that the digoxin becomes toxic if the patient's hypokalemic. So we really do not want the patient to drop into low potassium. We try to avoid that at all costs. So if the patient's potassium is within normal range, say like 3.5 or 3.6, that's still normal, but that's like, oh, I can see abnormal from here, right? Like it would be a priority to ask for a potassium supplement. So my point being is, remember digoxin had its own therapeutic range. So obviously you need to know if it's below or above the therapeutic range. If it's above the therapeutic range, it's toxic. If it's in the therapeutic range, but the potassium is about to go low, once that potassium goes low, it's gonna become toxic. So anyway. Beta blockers, what are the side effects? Calcium channel blockers, what are the side effects? Beta blockers, who do we not give them to? Or who should we be very cautious? Digoxin is positive ino, negative chrono. What were the know the therapeutic range for digoxin? What are the adverse effects? ACE inhibitors, recognize the names. What are the adverse effects? TPA, no, like streptokinase, alteplase, tenecteplase, retaplase. Obviously, the main adverse effect is going to be bleeding, duh. But if the bleeding becomes too bad, what drug would we give? If where would you expect to use those drugs? And I already talked about the heparin. We monitor APTT. We monitor the platelets. So heparin can cause bleeding, but then heparin can also cause HIT, which is the heparin-induced thrombocytopenia. That's why we're monitoring the platelets. It's an allergic reaction. It causes the body to start. It can cause the body to start, the body's own immune system to start attacking the patient's own platelets. So that's why we're monitoring the platelets. So that's why for both heparin and enoxaparin, even though enoxaparin is a watered down version, it still could cause the body to have kind of like this allergic reaction that starts attacking the platelets. So heparin, APTT, what do we use to reverse it? Warfarin, PTINR, what's the therapeutic range for that for most patients? And if the number's too high, what we use to reverse that? Statin drugs, what do we give it for? What were the 1 or 2 big adverse effects or organs that they could affect? Niacin causes flushing. A lot of people miss that. So niacin can make the patient kind of turn a little red. That's normal. It's not nothing to really worry about. Adenosine, what's the safety precautions we need to take when we're giving adenosine?
You give a benzo before and you have the crash cart nearby.
Okay, what else? Those aren't the priority, but what would be the priority one? Satlik.
Place them on the monitor.
Yeah, place them on the monitor. Why am I saying the monitor is going to be the priority?
Because you're stopping their heart, so you want to know if it restarts.
Yeah, so it's rare that the heart doesn't restart. The heart should restart once the drug wears off. The drug only lasts 6 to 10 seconds. So about 6 to 10, 11 seconds, the heart should be all of a sudden come back and start firing. We need to be on the heart monitor because what if you're sitting there and you're like, oh, it seems like it's been a long time. The patient's not moving, right? You want to see about if after 11, 12, 13 seconds, the heart's not restarting, the patient is dead. We need to code them right there. So that's why we have the crash cart. But crash cart is not a priority until you know that we need to use it. So that we put them on the bedside monitor so we know we need to use it. So, but yeah, you were totally right about the benzo. And what's the expected rhythm after giving adenosine? So after adenosine, they go asystole, which is flatline, but then what are we hoping the rhythm is after it comes back?
Just normal sinus rhythm.
Yeah, just normal sinus rhythm is what we expect. Nitroglycerin, the patient teaching as far as like, remember we talked about, you could take 3 pills, that whole thing with when do you call 911, what do you do? How many pills can you take? What's the expected adverse effect of the nitroglycerin? What should you never take? What other medications should you never take when you're on nitroglycerin? So that stuff. What type of weather should you avoid with that? Nitroglycerin, why is it given sublingual versus oral? Why am I have to put this under my tongue instead of taking a pill? EpiPen, remember we talked about the EpiPen with bee stings. So how do you teach people about the EpiPen? What do you teach them? Extravasation, I think you guys know that. The first thing is stop the infusion, call the MD, and then the other stuff we talked about, extravasation. How do we know if it's extravasation versus infiltration? Amiodarone has a lot of toxicities, so kind of know what the toxicities are and what we monitor for that. And amiodarone, tell me about amiodarone's half-life. Antibiotics, know about what a culture insensitivity is, and that it's our responsibility to get a culture insensitivity, or to ask the doc if they want a culture insensitivity prior to administering the antibiotic. Remember that antibiotics are only for bacterial infections, not viral infections. The antibiotic, so we give the culture insensitivity prior to giving it, then the first antibiotic type we're going to give, if we don't know what the infection is probably a broad spectrum. Why broad? Because we don't know what it is. So broad will kill a whole bunch of things. Hopefully it'll kill the one that our patient got. Once the culture comes back, then we switch over to the narrow spectrum. Why do we go from broad to narrow? Because the narrow will work better, but also the more often we use antibiotics of any type, the more frequently we use antibiotics, the more the bacteria can see an antibiotic, the more likely it is to figure out a strategy to beat it. So in other words, the frequent use of antibiotics is a risk of causing antibiotic resistance, because the bacteria will learn. We want to switch from the broad to the narrow because because the narrow should work better, but also we want to switch away from the broad as soon as possible, because the more often we use broad spectrum, pretty soon more drugs will develop antibiotic resistance to them. And then that would be bad. So overdosing versus underdosing. Remember, overdosing could give you a lot of nasty side effects, but it's probably going to kill all the bacteria. So too large of a dose doesn't contribute to antibiotic resistance. Too low a dose does. Prescribing an antibiotic to a patient once a year, twice a year for some bacterial infections, that's limited. But if a patient goes and then every month they're getting an antibiotic for just any little coughing or sneezing, the more frequently we use them, the more likely they're going to develop antibiotic resistance. So that's why we don't want to treat viral infections with antibiotics, because they don't work on viruses. And so H. pylori, that's why we're using multiple antibiotics, to make sure that the H. pylori doesn't develop antibiotic resistance. What other drugs do we give along with antibiotics to a patient with H. pylori?
API.
Yeah, something to decrease the acid. Is that it?
Sulfactrant?
What'd you say, Melvin?
Sulfactrant?
I don't understand what you're saying, dude.
Never mind.
You're like, type it in the box. Sucralfate?
Right, sucralfate. That's sulfactrant.
She also gives Saccharomyces.
Yeah, so we might give probiotics. We might give like Pepto-Bismol, but remember Pepto-Bismol is kind of like aspirin, but it's kind of like an antibiotic. It's kind of like all kinds of things. Yeah, but the main thing is we want to kill the bacteria, but we also want to kind of protect the ulcer from the acids. We decrease the acid, we'll prescribe something kind of protect the ulcer. So you could give sucralfate too. Remember, antibiotics all of them, they have, not all of them, but the stronger ones, those are really at risk for causing super infections. The stronger ones also typically cause allergic reactions. So penicillin's the #1 drug in the world for as far as like allergic reactions. You know, the most common allergy in the world is penicillin. And if somebody has an allergy to penicillin, they probably have a cross sensitivity to cephalosporins. Antifungal drugs, what do those end in?
Azole.
Yeah, azole, like ketoconazole, miconazole, clotrimazole. Remember, you want to really take those with food because a patient can get like really upset stomach and increase your fluids. So take with food and increase the fluids. What's the antifungal drug that we give via IV?
Amphotericin.
Yeah, amphotericin. So that's IV only, and we only give that for really bad, severe fungal infections that are systemic throughout the whole body. What organ can the amphotericin destroy very quickly? Yeah, kidneys, Kathy Sanchez, thank you. So yeah, amphotericin is one of those super nephrotoxic drugs. Remember, you know, you should kind of have a little mini list of what drugs are like really bad for the kidneys. So the aminoglycosides, those are things like the tobramycin, the gentamicin, the streptomycin. The aminoglycosides are very nephrotoxic. So those you're going to expect to draw both peak and trough, especially peak. Amphotericin is really nephrotoxic. There's a fungal for people with the candidiasis, which is a fungal infection of the mouth, or you can have candidiasis of the vagina as well. So if it's in the mouth, we use the nystatin, the switch and spit, or the switch and swallow. Either one, whatever the doctor prescribes. There's a drug. It's not an aminoglycoside. That was cool. That was a cool drive-by kid comment. So it's not an aminoglycoside, but it ends in mycin, and that's vancomycin. So what do we use vancomycin for?
So MRSA, C. diff.
Yeah, MRSA and C. diff are the big ones. Can we use it for other Yeah, like we use it for a lot for people that have penicillin infections as well, or other penicillin allergies as well, or they have allergies to other antibiotics. So vancomycin is a big one. We use that frequently in the hospital. What was the big adverse effect or safety concern with vancomycin? Yeah, malaria, red man syndrome. So the red man syndrome is they literally turn red, which that's not concerning. What's the concerning part that could happen besides them turning red? Malaria. So remember, they can turn red. So red man syndrome is they're turning red, but sometimes when they turn red, their blood pressure also starts dropping as well. So that's the big, thing you want to watch out for. So the red man syndrome, because of the potential drop in blood pressure, how do we avoid that, or how do we mitigate that? We try to infuse the drug slowly because it's given as an intermittent IV infusion. Usually it's like X number of milligrams in 250 ml bag of saline or D5W. Or if their skin starts to turn red, it's like, oh, I'm going to take their blood pressure. If their blood pressure is fine, I'm just going to slow the infusion down because they were turning red. Might give them diphenhydramine as well. Remember that vancomycin can also cause ototoxicity, so hearing issues. Nephrotoxicity, so kidney issues as well. All right. For someone who's being exposed to TB but is tested negative, what's the drug that we'll give to kind of prophylactically, hopefully, prevent them from developing active TB? Yeah, isoniazid, INH. For that Saccharomyces boulardii that we take, because it's a probiotic, so it restores some of the good bacteria. So hopefully the patient doesn't get a super infection. When do we give that in relation to the antibiotic? Because they're going to be antibiotics. You don't want to give the antibiotic and the probiotic at the same time, because the antibiotic will kill the bacteria from the probiotic. So normally that's about 2 or 3 hours afterwards. So you give the antibiotic, and then 2 or 3 hours later, that's when you expect to give the probiotic. I already said know when we do the peak, know when we do the trough. If someone has a UTI and they're experiencing dysuria, what drug would you potentially ask the provider for?
Pyridine.
Yep, phenazopyridine. Phenazopyridine. All right, so that was it for my quick little quick topics to review. So look, it's mostly like bigger stuff. So if you find yourself trying to learn like all, at this point, it's late in the game. So you don't want to try to learn like, oh, I need to know all 12 of the major adverse effects of beta blockers. Maybe learn the top 3 if you didn't learn them before. Like when you go like, notice most of those questions are on the bigger kind of issues, right? So, know the basics before you try to get advanced is what I'm telling you, especially for the final. And I would just say, the week 1 stuff, because in general, is every class, every term, the week 1 scores are usually pretty weak. The respiratory quiz is usually pretty weak, and the cardiac quiz is pretty weak. So go over the stuff I just gave you, and then maybe look back over week 1, especially the terms like that pre-work I did for the week 1. Look over the pre-work, make sure you understand it. And then the respiratory, especially regarding like asthma and its treatment, and the BAM slam. Cool. That's it. I'll stick around. Oh, bless you, Jones. Bless you.
Thank you.
Yeah. I'll stick around if anybody has any questions.